Hello and welcome to Eyes on Research, the podcast that digests the latest scientific innovations in eye research using simple and understandable terms. I am your host, Thales Guimaraes, medical doctor and clinician scientist at Moorfields Eye Hospital. Hello and welcome to another episode of Eyes on Research. I hope you're having a great May so far. This episode was supposed to air last week, and apologies for that. I have a very good justification for it. I was in a medical conference last week, and this conference was overseas. It was in the United States. I stayed there for a few days, but I took everything, right? I took my microphone, my headphones, and my laptop, and I was expecting to be able to record there. And unfortunately, I stayed in a very nice hotel, so I'm glad. But unfortunately, the room of the hotel was too echoey. There was a lot of echo going on, so I tried my best. I tried a few takes, and it just didn't work. I couldn't barely hear myself, right? So I have to push back everything by 1 week, and here we are. So today we'll be talking about keratoconus, its causes, what it is, and what are the currently available treatments. And just to put things into perspective, keratoconus is a relatively common corneal disorder. It's amongst the most common things in the cornea. And in some studies, it varies right across different populations, but in some studies, it has a prevalence of around 1 to 2,500 cases per 100,000 cases, right? So this makes it relatively common. It's a condition characterized by a progressive thinning of the cornea, causing a cone-shaped bulge, right, to develop, and this causes vision loss. Now, kerato means cornea, right, and conus means cone. So it's essentially what the name suggests. It's the cornea which is shaped as a cone. Now, the cornea is this clear, transparent window that we have in the front of our eyes. It is usually shaped as a dome and is the outermost layer of the eye. And this is the biggest lens that we have in the human eye in terms of refractive power, with around 43 diopters of refractive power. This means that without the cornea, humans would require pretty strong glasses. The way that we see things, and if you are a follower, if you listen to us frequently, you will have heard this many times. I talk about this almost in all episodes. So if you are a frequent flyer in this podcast, please keep ahead 30 seconds. Otherwise, let me just walk you through how we see things. So the light comes from our own very beautiful star, the sun, hits the objects here on Earth. The light bounces from the objects and comes right straight into our eyes. It passes, the first thing that it touches is the tear film. It passes the tear film and it hits the cornea, which is this huge lens that we have in the front section of the eye with its huge refractive power. After it's refracted by the cornea, it passes a liquid named aqueous humor, and then it passes through an aperture like a camera, right, that we have named pupils. After it passes the pupils, it goes through our own very lens inside the eye as well, named crystalline lens. And then it passes a space that's occupied by a transparent gel-like structure named vitreous humor. After this, it hits the back sections of the eye in a film-like tissue named retina, which is composed of many millions of light-sensitive cells. The light-sensitive cells are triggered by the photons of light, which then sends this information to the brain via electrical impulses. Now, the question is, why does the cornea have higher refractive power than the lens that we actually have inside our eyes, the crystalline lens? And for perspective, the cornea provides around 2/3 of the refractive power of the eye, and this owes to the fact that the speed of light changes considerably while traveling from the air into the cornea, right? To give you a little bit of a better perspective here, the index of refraction in the air is 1. The corneal index of refraction is 1.38, so that's quite difference, right? And to put things into perspective again for you, who may not be used with these terms, you may have seen in the water that the reflection of things is a little bit weird. That's because the index of refraction in the water is 1.33. So the index of refraction in the cornea is even higher, right? So the difference is even steeper. Now, because the change in refractive index between the cornea and the aqueous humor, right, which is the next thing that it passes through after it passes the cornea, right? Because the difference between these two is small compared to the change at the air corneal interface, it has a negligible effect in the refraction, right? Now the cornea is horizontally oval, measuring around 11 to 12 millimeters horizontally in normal size corneas, and 9 to 11 millimeters vertically. So what causes keratoconus, right? Now you understand what it is. Truth is, we don't really know for sure in all cases. All right, I'll see you all guys next week for the next. I'm just kidding. Let's keep here and hear me out. Sometimes it appears to be genetic, while other cases it appears that there's a largely environmental cause for the condition, right? So it varies a lot. Indeed, we have identified more than 10 genes that are associated with familial keratoconus. So genes that put people under higher risk of keratoconus, and this is the type of keratoconus that runs in families, right? Also, it's part of the spectrum of many multisystemic disorders. These are diseases affecting multiple systems of the eye, right? So things that come to mind now are Ehlers-Danlos syndrome, Down syndrome, Bardet-Biedl syndrome. These are all syndromes affecting different parts of the body, which keratoconus is one of the features. In terms of the environmental factors, right, and these are the most common, keratoconus is associated with a few things like eye allergies and excessive eye rubbing. The main factor actually is excessive eye rubbing, right? And why is that? The reason for that is that eye rubbing, so the act of rubbing your eyes, causes thinning of the keratocytes. Keratocytes are a specialized fibroblast cell that we have within the stroma of the cornea, so within the cornea. The function of these cells is to maintain the collagen scaffold, right? The matrix of the stroma. And what is really interesting is that in some studies, it was the degree of effect of the eye rubbing in the development of keratoconus depends on the period and the force of the act of performing the eye rubbing. So that means that the more you rub your eyes, the stronger you rub your eyes, the more likely it is that you put yourself under a higher risk of having keratoconus. The typical symptoms of keratoconus, they often start in the late teens. In some cases, again, it varies a lot, but usually starts in the late teens to the early 20s and gets worse with time. And this with time, I'm talking about 10 to 20 years, usually. It typically affects both eyes, but it can be quite asymmetric, right? So it can affect one eye in a worse way than the other. So patients affected with keratoconus typically have one eye that's the best vision, right? And it may also be that you only have, or a patient only has a keratoconus in one eye, right? And then you think, the other eye I don't have anything, but it may as well be that on your one eye that you have the keratoconus, it's on a very early stage, and on the other eye, it's even earlier, so it's not even detectable. We do a very specific test that, has modified the field, the cornea field, which is named topography. And there are other possibilities, there are other tests. But the one that we have used for longer, I would say, is topography. So sometimes you may see changes in one eye and not in the other. So it's very important to keep following up with your doctor, even if that's the case on only one eye. So in terms of symptoms, the on the early stages, patients have mild vision blurriness, some distortion of vision. That's when straight lines, they look bent or they look wavy, right? Increased light sensitivity and glare, redness in the eyes, and sometimes even swelling. Now, in the late stage, that's when you have the very blurry and or severely distorted vision, increased short-sightedness or astigmatism, which may not correct with new glasses prescription, right? And also some patients, because of the shape of the eye, right? Remember, it's a bulge shape. Literally, it's cone-shaped, right? There's a bulge in the front section of the eye. So contact lens may not fit properly, right? It's one of the things that patients complain a lot. They don't fit as they should. And to understand a little bit more about short-sightedness, a little bit of self-promotion, we have an episode a couple of weeks ago about short-sightedness. Go check it out. This will make a little bit more sense. There are, in rare cases, some complications as well. So the most important one being corneal hydrops. Now, this is very rare, but it may happen and it may cause quite a story. So, it's important to keep following up, even if you are stable. It happens essentially when a part of the cornea breaks, causing fluid that's inside your eyes to flow into the cornea, which otherwise shouldn't, right? This causes pain, and it's, in most cases, excruciating, and swelling, as well as sudden vision loss. So it's one of the only causes of sudden vision loss in the cornea, in patients with keratoconus, associated with the cornea, of course. Now, patients may need to wear some contact lenses, right? Some therapeutic contact lenses to reduce the pain, and also some eye drops may be prescribed. But it often goes away within a few weeks on its own. So, is there a way to prevent having keratoconus, right? That's a good question. And in most cases, it's not actually preventable. But don't forget the advice that your mother gave you: do not rub your eyes. Because you can actually reduce the chances of having keratoconus by, you guessed, not rubbing your eyes. Making sure contact lenses fit well. Because think about this for a second, right? When you put contact lenses, if they don't fit properly, you'll be rubbing your eyes more than you should. Similarly, other diseases in other parts of the body that may cause a discomfort in the eye, and things like allergies, right? Think about hay fever. One of the most common traits of hay fever is, scratching the eyes, rubbing the eyes, right? So it's very important to control the allergies as well, so you stop rubbing your eyes. We also recommend as well protecting your eyes from UV radiation, right? So ultraviolet radiation causes damage in a few tissues inside the eye. So, we always recommend wearing sunglasses. And, in case you are wondering if sun can actually cause damage to the cornea, yes, it can. It can cause something named photokeratitis, which is essentially, it's a burning of the cornea. I would highly recommend checking out our episode on a sun-induced damage. We have an episode a couple of months ago on that, so it's you will understand why it's important to protect your eyes with proper UVA, UVB protection. Doesn't need to be the most expensive glasses you can buy, but something that's actually certified for UV protection. Now, we spoke a lot about keratoconus, what it is, what are the symptoms, how do we manage keratoconus? Now, of course, it varies according to the severity of the disease, right? So there's not a single method that works for everyone. In early stages, you may not even need anything. Usually, spectacles are necessary and they can be used early on to provide optimal vision to patients. This is very important, right? And frequent changes in glasses are something that's really common in patients with keratoconus. More frequently than that, though, and I'm going to say, almost, 80% of the patients that I have seen with keratoconus, they went to use rigid contact lenses. Now, rigid contact lenses typically are required when there's a higher order, a higher degree of aberration caused by the abnormal shape of the cornea, the abnormal surface of the cornea, right? And it may cause astigmatism as well. We'll have an episode in a few weeks. We'll be talking about refractive error, but it's one of the causes of increased astigmatism as well. Now, these are the most, or should I say, the earliest treatments. When there is scarring in the cornea, which is at a later stage, a corneal transplant may be necessary. There are different types of corneal transplants, right? You can remove just a part of the cornea, or you can remove the entire cornea. It depends on how deep this scarring goes. So you can sometimes preserve a part of the original corneal, and the transplant, of course, comes from a donor, right? There are some options in the middle of this. So in the middle of rigid contact lenses and corneal transplants, more recent options. Artificial rings that can be placed inside the cornea, which is a procedure that you do and put these rings throughout the circumference of the cornea. We name these corneal ring segments. Artificial lenses that can be placed inside the eyes to correct vision as well. And something that's called collagen cross-linking. Now, cross-linking has thoroughly modified the field. It is done by essentially stiffening the cornea. And it's done after putting eye drops in the eyes containing riboflavin and then shining UV light on the cornea. This essentially adds bonds between the collagen fibers in the cornea, making it stronger. So it is a minimally invasive procedure that can halt or at least slow the progression of keratoconus. So, it was a huge step forward when we started doing this. It really modified the outcomes of keratoconus. Many less patients are requiring transplant, because if you treat this early enough, in some cases you can actually halt the progression altogether, right? So the patients don't actually evolve. But usually a mix of treatments are necessary for better results, and the best person to decide this is your doctor. So remember, there's not a single treatment for one patient, right? You need to treat each patient individually, and sometimes you need to combine different avenues of treatments to provide the best outcome for the patients. That's it for today. I'm not extending this longer than we should. Thank you so much for listening to me today, and I hope to see you in the next episode. Just a few disclaimers now. We have social media accounts. If you search @Eyes on Research on all of your social media, you can find us wherever you prefer: LinkedIn, Twitter, TikTok, Instagram. We have it all. We post short videos all the time of teams that did not go on to become full episodes, so please do check it out. I'm sure you'll find something interesting there. And we also have a support page, which is the Buy Me a Coffee website. There's a link in the description of this episode. We also use that as a blog, so we have articles there that were reviewed by me. So I put them all together. I handwritten them myself. So I do my own research, and I am a researcher. So the information that I'm providing is actually reliable information, and I put the links, the hyperlinks on the post so you can follow and see for yourself. So it's curated information, high level information, and I'll digest it into simple terms. So do check it out as well. I'm sure you'll enjoy. We have some posts. Just started this website a couple of months ago. We have like 6 or 7 posts, but we have new posts coming there every week as well. So do check it out. It's completely free to follow us there. So if you follow us, you'll be notified when new articles are up. However, that's also our support page. So if you like what we do, you can certainly support us there. It's completely optional, but highly appreciated. And if you do support us, you get access to very, very cool perks. Like, for example, suggesting a theme for a short video or for a post in the blog, an article, a full curated post, or even a podcast episode, a full podcast episode. So go check it out. I'm sure you'll enjoy. Otherwise, I'll see you next week. Take care of yourself, take care of your family, and I'll see you soon. Bye-bye.